So good afternoon, everyone. I would like to thank the organizers for inviting me to present about the post-traumatic endophthalmitis. It's, as you know, the endophthalmitis in general is a very devastating complication and more dangerous after the penetrating ocular trauma. It accounts for 25 to 30% of all endophthalmitis cases. And most of the organism is enucleation from the normal flora of the conjunctiva or from the environmental microorganisms. The incidence of positive culture endophthalmitis account for ranging from 4 to 17%, and most of these cases present in the first to third days after the trauma. So the presence of intraocular foreign body is very important to identify initially on presentation by CT scan, just to make sure the foreign body is not there. If it's there, those patients have high risk of endophthalmitis. So the risk factor, as we mentioned, the intraocular foreign body is the very important risk factors. The second factor is disruption of the lens capsules and zone 1 trauma. The trauma in the oral setting is again another risk factors, and failure to initiate the prophylactic antibiotic is another major factors for developing endophthalmitis post-traumatically. So in the univariate analysis, it shows the 5 major risk factors, including the dirty wounds, retained intraocular foreign body, ruptured lens capsules, delayed primary repair beyond 12 hours, and the rural setting trauma. And the multivariate analysis, it shows the 3 major risk factors, including dirty wounds, ruptured lens capsule, and delayed primary repair beyond 12 hours. The most important encountered organism was coagulase negative staph, followed by streptococcal species. And the polymicrobial infection is another important organism. Fungi is very rare in these cases, especially with the, it's more with the vegetable material trauma. So clinical diagnosis in the setting of severe trauma needs high index of suspicion. As you know, severely traumatized eyes is sometimes very difficult to examine those patients. So you have to have high index of suspicion. And you have to differentiate between bacterial and fungal infection. Bacterial usually they present acutely and they progressively rapid to panophthalmitis compared to fungi. The fungi usually indolent course or subacute course. Sign and symptom is exactly the same as in endophthalmitis cases. Very important to differentiate 2 major entities that can mimic endophthalmitis, including fecal-anaphylactic endophthalmitis, which is lens-induced inflammations, or post-traumatic non-infectious or sterile inflammations. So diagnosis of endophthalmitis in general, it's a clinical diagnosis. If you suspect it, you have to treat it. You don't wait for the investigations. The other diagnostic tool is very helpful, but it's not for the diagnosis, just to helpful to identify any other comorbidity like retinal detachments, choroidal hemorrhages, or presence of intraocular foreign bodies. Culture is very important in these cases to culture the main wound, to culture the aqueous and vitreous. This slide is very important slide. I think this is the most important slide of my talk, is to identify the high-risk cases. So if you identify the high-risk cases, then you can initiate the prophylaxis antibiotics immediately, promptly, without any delay. So the high-risk cases include the delayed primary repair more than 24 hours, dirty wounds, breached lens capsule or lens injury, retained intraocular foreign body, and oral setting trauma. So prophylaxis antibiotics in form of systemic, intravitreally, or topical. Systemic, we preferred vancomycin and ceftazidime as the best combination to cover both gram-positive and gram-negative. However, the 4th generation fluoroquinolone is another important antibiotics can be used due to its high therapeutic level in the aqueous and vitreous after systemic administrations. Intravitreal antibiotics, another modality of prophylaxis. We preferred here vancomycin and ceftazidime as the best combination to cover both gram-positive and gram-negative. So how do you manage these patients? The first management is to close the wound. Once you have trauma, penetrating injury, you have to close the wound as soon as possible. Then during the primary repair, you have to culture the wounds, aqueous and vitreous specimen. And then initiating prophylaxis antibiotics immediately in high-risk patients. Use of corticosteroid is debatable in these cases. It's contraindicated in fungal infection. However, in the bacterial infection is very beneficial. The main line of treatment of post-traumatic endophthalmitis is vitrectomy. So in these cases, we don't follow the endophthalmitis vitrectomy study. Traumatic endophthalmitis treated by vitrectomy. So this is some of prophylactic antibiotics. Antibiotics can be used systemically, topically, intravitreally, and the doses. and the antifungal also medications. So the corticosteroid use, as mentioned, is very beneficial, especially in bacterial setting. As you know, the bacterial toxin is significant, but also the host inflammation is very important in damaging the organ, the tissues. So it's a very beneficial in these cases. However, it's debatable, and the dose, as you know, dexamethasone 0.4 and 0.1 ml. So pars plana vitrectomy is, as I mentioned, is the main line of treatment. It's indicated mainly in these situations: the presence of virulent or multiple organisms, loss of red reflex, substantial ferrous hyperoxygenicity or retinal detachments, and presence of intraocular foreign body. As you mentioned, endophthalmitis vitrectomy study is not applicable in these cases. So we don't look for the visions. Even no light perception, we need to treat those patients. So the use of silicone oil also is very important. It increases the yield of the vision postoperatively up to in around 60% to get 2200 vision or better. So prognosis, the poor prognostic factors, delay in the diagnosis and treatment, poor visual acuity at presentation, light perception or worse, associated injury like retinal detachment or choroidal hemorrhages, polymicrobial infection, and associated severe inflammations. As we mentioned, the use of silicone oil is very important in these cases. Presence of retinal detachment is poor prognostic factors. In those patients, usually they progress to phthisis bulbi, and then the evacuation rate in these cases is around 17%. So in conclusion, high index of suspicion is very important in these cases. Identifying high-risk patient is very crucial in these cases, and it's promptly initiating of the prophylactic antibiotics. Pars plana vitrectomy and intravitreal injection is the main line of treatment. And thank you.